Good morning, and thank you for joining us at the Houston Methodist DeBakey Grand Rounds. I'm Man Malafchi. I'm one of the cardiologists in the cardiac imaging group. And before introducing our Grand Round speaker for the day, I have a few items to remind you of. Please use the microphones when you want to ask questions. We're broadcasting this live worldwide on our YouTube channel, which is one of my top subscriptions, and then Vimeo. And then this recording is live, and you can always view it after as well. Please like and comment and subscribe. And then for our viewers, if you also want to submit a question, you can text DeBakey to 37607. There's a couple upcoming activities. One is the CV Nursing Conference on November 14th, and then the other is Pumps and Pipes on December 8th. These are all hotly attended. So it's my absolute pleasure to introduce Dr. Hector Michelena. Dr. Michelena graduated with honors from Central University of Venezuela, and then did internal medicine at Yale Affiliate Hospital in San Rafael. Then he was clinical cardiology at MCP Hanneman, and cardiovascular imaging at Temple. He also trained at Mayo Clinic in advanced adult cardiology. And then he stayed in the Mayo Clinic afterwards, where he's now a professor of medicine. And he's really, the bio says he's a clinician, researcher, and educator. I would add he's a master clinician, educator, and researcher. And then he's received multiple awards for best provider and top researcher at the Mayo Clinic. He was also chair of the ACC Latin American Conference between 2017 and 2019, as well as multiple ACC committees. And he's on the board of directors of the Heart Valve Society, which is a huge interest for all of our grand rounds in valvular heart disease. He has more than 300 peer-reviewed publications, and I was really excited to be able to invite him for grand rounds because he had so many huge contributions in the field of AR, which is one of my passions. And then he's, beyond AR, he's, a recognized expert in bicuspid valve disease, aortopathy, mitral valve disease, and so many other things. So without further ado, Dr. Michelena, he's going to talk about state of the AR. Great topic.
Thank you so much, Dr. Malaji. That was very sweet, and I appreciate it very much. I had a very good time with you guys yesterday when we went for dinner. And once again, Dr. Malaji, thank you for the invitation, and that extends obviously to the rest of the Methodist community, and of course to Dr. Zogby and Dr. Shah and Dr. Quiñones. So, state of the aortic regurgitation. It looks as though aortic regurgitation is the forgotten valve, but clearly not for us, Dr. Malaji, is it? Not for Houston Methodist, not for Mayo Clinic either. So we're going to talk about AR a little bit, and I invite you to sit down and relax, and let's go through this. You see, we have a line where there are ancestors, present and future, and right now we are obviously in the present, which is what we have, and some of us will not be here in the future, and we will become ancestors. And it's just very interesting to see how the human mind and how the importance of ancestry is, whether you're famous or not. I mean, obviously Leonardo was very famous, but these are the eddy currents that keep the aortic valve open, and it took more than 500 years for us to be able to see it by actually 4D MR. And that was already in his mind. So that's how the world works, huh? These are my disclosures, which have not much to do with what I'm talking about, actually. It's very important to recognize clinical echocardiographic, MRI, AR severity and prognostic assessments, discuss the difference between sexes in aortic regurgitation, identify differences between bicuspid and tricuspid aortic valve in aortic regurgitation, know a little bit about the treatment, particularly for the young patient, and deconstruct a little bit the AR management guidelines as well as our egos, and feel a little bit of Pablo Picasso today. It's Picasso Day. So Nietzsche said it very clearly, we have art in order not to die of truth. So that's what I use so that I don't die of truth. So who knows what town this is? Pablo Picasso said, art washes away from the soul the dust of everyday life. This is my picture in my excitement from the taxi when I was in Malaga, going to see, that's where Picasso was born. And that was my excitement, taking a picture because I was going to see him. And it would seem that like the right picture is longer, but it's not. He used to play with perspectives like that, such that if you go to the left side, you see this. Then if you go to the right side, it's the same painting, huh? You see it this way, which is unbelievable to me, particularly because little young Picasso was only 15 years old in Barcelona when he painted this called Science and Charity, which is what we all do, isn't it? If you don't see, you don't know. So I hope I can show you some things that you won't forget. These are Las Meninas. Las Meninas are originally from Velázquez, and there they are. And you would never know that this is Picasso's rendition of the Meninas, and this is the original, which was about 300 years earlier. Okay, so echo evaluation, new things, echo volume and strain, early asymptomatic LV markers, the importance of MRI, the importance of women, the importance of bicuspid aortic valve. Those are the things that we're going to talk about today. And let's try to get inspired and start working here. So, aortic regurgitation is not the most common disease, but it's a disease to take into account, number one, and it's a disease that affects more younger people, and it's a disease that affects mostly men, as you can see. In this study where we used what we considered clinically significant AR, which is more than 3 to 4 plus AR, looking at echo surgery and pathology, we found interesting things. We found that for tricuspid valve patients, about 40% were actually unclear etiology, had a little bit of root dilatation, and I think those are the older patients that we see with AR, older men with AR that have hypertension and that have a degeneration, sclerosis of the aortic valve, and usually have a tricuspid aortic valve, obviously. Then bicuspid aortic valve accounted for almost half, and this is a significant increase from previous pathological reports. The most common isolated mechanism of the valve per se is cusp prolapse for both tricuspid and bicuspid, isolated mechanism. But the most common is to see mixed mechanisms in up to 70% of these people. And the ones that tend to have the most mixed mechanisms are bicuspid aortic valve. Why? Because they have big LVOTs, big STJs, and they have prolapse. So they have combination of aorta mechanisms and combination of valve mechanisms. Now, there are two age peaks, as you can see. There is the age peak, which is still relatively young, of tricuspid aortic valve. These are patients referred with significant AR, meaning more or equal to 3 plus, meaning more or equal to moderate to severe. And bicuspid aortic valve, you see they're in their 40s. They're mostly males, particularly bicuspid. I mean, look at the percent of females. Okay, it's a little higher, obviously, for the tricuspid leaflet. And there's an important thing to say here, which is bicuspid aortic valve patients present 2 decades younger. These are patients that present in their 30s, 40s, and 50s with more aorta dilatation, and we have to devise a plan for them, lifetime management of their valve. What does that mean for us as imagers? That means that for me as an echocardiographer, I have to define the anatomy first. Is it bicuspid or tricuspid? I have to define the mechanism. Why is it happening? And I have to define the severity. And I have to look at the aorta too. So that's what we have to do. So obviously we need to be able to recognize a bicuspid aortic valve. Here's a typical right-left fusion with doming, systolic doming there, right-left fusion opening like a football. Again, the doming there, the opening football-shaped. And we should be able, by TTE, to measure most of the aorta, meaning actually a great part of the thoracic aorta, meaning the LVOT, sinuses, ST junction, proximal ascending. You go up one space, you measure the mid-ascending, you go then up to the notch, and you measure You can measure the arch, you can measure the descending. This is obviously less trustable than these others, but these others are not bad. Now, there's these guidelines, which were updated from 2003 in 2017, which are the ECHO guidelines. And I like several things about them. They reinforce the fact that we need to do a comprehensive analysis. You cannot put your bets on one thing alone, you know? It is critical to look at mechanisms. It is critical to look and use vena contracta, and we're going to learn how to do it. It is very important to look at the flow convergence without touching anything. If you just throw color there and there's a huge flow convergence, your mind has to say this thing is moderate or more. And I'm going to find out if it's 3 or 4. So looking at the valve is the other thing. That's critical because that can tell you already the mechanism even without putting color on it. So obviously the diagnostic algorithm is important. Now we have to use all information available, but there's a critical prerequisite for chronic AR, which is that the LV has to be big, okay? And sometimes people dilate LVs in very different ways. So sometimes you will measure 2D end systolic diameter, 2D end diastolic diameter, and the LV is not big. And then you measure volumes and it's big. Or you measure volumes and 2D by echo and it's not big, but you do MRI and it's big. So this is a very important thing to establish. And it can help both ways. It can help say, hey, this is 2 or less because this LV is completely normal, or this is more. Because you have to have LV dilatation to accommodate chronic severe AR. So what type of information? I like how Dr. Sogby used to divide it in the 03 ASC guidelines on specific signs and supportive signs. And obviously, a big specific sign, meaning that it rules the disease in, it has that power, is the vena contracta. And obviously, there are supportive signs like the holodiastolic reversal in the descending thoracic aorta or abdominal aorta and the pressure half time. And obviously, quantitative parameters, effective regurgitant orifice and regurgitant volume. This is very important. Vena contracta for aortic regurgitation traditionally and in most studies has been done with the beam of echo perpendicular to the flow. What happens there? You need to identify the full jet. The head of the jet, which is the flow convergence, the neck, which is the vena contracta, which by definition is the smallest measurable distance between the flow convergence and the rest of the jet. Now, when you look at it perpendicular, note that the flow convergence breaks into 2. It breaks into a little blue and a little red. Why? Because that's how the flow is breaking. You have to see this thing in order to measure a vena contracta. If you're not seeing this thing, you're not measuring right. Now, you have to zoom as well. And this is the flow convergence, which looking perpendicular appears blue and red components. And then this is the smallest diameter between that flow convergence and the rest of the jet. And obviously you can do that for baby jets as well, as you can see. So this has been shown, vena contracta, to have a very good area under the curve for diagnosis compared to other semi-quantitative, and more recently, albeit a small number of patients, importantly 60% bicuspid patients, using vena contracta and LV volumes, those two are very powerful, you know? So these are important things to remember, and obviously you have to know that less than 0.3 is mild and more than 0.6 is severe. Now, pressure half time in my book is worthless for chronic AR. Chronic, well-established, well-tolerated AR is worthless to measure this thing. Why? Because this thing just reflects how fast pressures equalize from aorta and left ventricle, basically. So you can have mild AR and have a pressure half time of 30 if you have a very severe grade of diastolic dysfunction. Okay. Now, where is it good? It's good where colored Doppler is not, which is subacute or acute AR. If you throw a colored Doppler on subacute or acute AR, you don't see much. Okay? This is subacute AR in the OR, getting ready, and you can see that it's just to and fro, and this valve is destroyed, obviously. And basically, this is the vena contracta. It's the entire LVOT. And an interesting phenomenon happens. The LV pressure is so high that it closes the mitral valve early. So when you do an M mode here, you don't see the typical M, but you see the initial and then it's closed because there's so much. And when you go to the belly, what do you see? You see the to and fro. Okay, of subacute AR. Now let's do pressure halftime here, and there you go. Okay, that's where it's helpful. So AR as a work of art. This PISA is not this. PISA is not this. PISA doesn't mean, please, I can't stand it anymore. PISA means proximal isovelocity surface area and is obtainable by surface or TEE in a lot of patients. I would say, my best opinion, 90% of MR and 70% of AR, okay? What do you have to know? That in order to calculate flow, we need an area and a TVI, a velocity. Why don't we use just the peak velocity? Because we're in a pulsatile system. To account for that pulsatility and the variations of velocities during that pulsatility, we have to use the TVI. You see, which is the area under this. It's really not an area. It's the measurement under this curve. So obviously that gives you a volume. In a non-compressible fluid system like blood, flow is the same at any given point. This is what everything is based on. Flow equals area times velocity. And that's where everything comes from. And it's just variations of that, as you will see. Obviously, if there's an area that's big, the velocity is smaller. If there's an area that's smaller, the velocity is higher. But at any point in the heart, the flow is the same, such that if you know 3 variables, you can know the one that you don't know. Okay? And this is the basis of PISA. What happens with PISA is the following. Blood organizes itself in shells or hemispheres as it gets close to the hole. Each one of those shells has a velocity. It's called isovelocity because each shell has the same velocity. Okay, so the velocity on this one is 20. The velocity on this one is 50, but it's the entire one that's 50. The velocity in this one is 100. So the velocity increases, but it's the same throughout the hemisphere. So what is PISA? PISA is really playing with the hemisphere that forms before the hole. That hemisphere, because of inherent lateral limitations of imaging of echo, is more of a circle than a real hemisphere. So what you're looking for really is a circle. Now, you can imagine that if you have the radius of a circle, of that hemisphere, you have the area, and then here's the area of the hemisphere, and if you have the velocity, well, area times velocity is the flow before the hole. So this is the typical eliciting of a PISA head, parallel to flow, parallel to the leak. This is an apical view, LV, aorta. It's going that way, it's going up, and if it goes up, baseline goes up. And you have to zoom a little bit, and you get the nicest circle that you can. You see, it's a clean circle. You know it's a hemisphere, but it looks like a circle. And you measure the radius, and you're done. So once you have that, and you can calculate that flow before the hole, where all you need is divided between by the peak velocity. It's the only measurement that uses peak velocity because it's instantaneous measurement, okay? It doesn't account for the entire cycle, okay? Both for AR, MR, TR, for everybody. And that gives you the area. And then with the area, once you have the ERO, well then now you use the TVI, the full TVI to get the regurgitant volume. So critical thing is that you're telling the machine to alias from red to blue at 40 centimeters per second. So you know that this hemisphere right here, its velocity is 40. And you know its radius. So you have the flow before the hole. That's it. And you do your calculation. And you need to know these numbers, more than 0.3 centimeters square of ERO, or more than 60 cc's per beat is certainly severe. And these numbers, and by the way, this is the first article of JACC Imaging in 2008. It's just to show that the quantification by ASE is predictive big time, mild, moderate, and severe of cardiac events, okay? And this obviously involves PISA. Now, let's do this exercise real quick here. This is an astute observer. So sometimes I say that you can diagnose AR without color. Sometimes, huh? So this is a very interesting one because you can see several things. Number one, the LV function is preserved. Number two, the LV is huge when you compare it to the RV, right? Number three, there is a shimmering and shivering of the anterior mitral leaflet there in a very Austin Flint manner. Nothing else causes that but AR directed to that leaflet. But there's something else hidden here. There's prolapse of that anterior cusp. That's why the jet is directed away from the prolapse and it's hitting the anterior mitral leaflet. And there's even something else hidden here, which is the blood pressure of the patient. Look at the difference between systolic and diastolic, right? So very big pulse pressure. So when I saw this is my real case. So when I brought the fellows and I said, how to diagnose severe AR with one parasternal shot, no collar. I know this is severe, okay? So now we look at the 4-chamber, and obviously that LV is huge. Now we look a little closer at the valve and we see partial, what it's called, I'll show you how to look at it, partial prolapse of the anterior cusp, which could be a bicuspid, but most likely is a tricuspid because this is the way that the right coronary artery, the right coronary cusp prolapses in tricuspid. And obviously, please look at this. This jet is directed all the way down, okay? So you are already parallel here. You can do your PISA here. You don't need to go anywhere else because you're already on top of it. Please see what Dr. Sogby writes in the guidelines. There's a huge flow convergence here, just with regular scale. That means this thing is bad. Okay, so what do? Well, you can measure your TVI. You have to, again, if the flow is, we said before, if the flow was going up, baseline goes up. If the flow is going down, like this jet, baseline goes down. So we're telling the machine that at 35, I want blue to alias into red, okay? Now, in order to see the beauty of life, sometimes you have to watch close and you have to zoom in, huh? So we have to zoom in for these measurements, for vena contracta and PISA, okay? So this is a beautiful circle. That is the radius. We know that the velocity of this hemisphere that looks like a circle is 35 centimeters per second because we told the machine. We have this, and we have our calculation. And it's whooping severe AR. But there's a little problem, echo math. Things have to make sense in life. So this patient had a total stroke volume calculated by the LVOT of 140. Now, if you take the 100 cc's of regurgitation, he's left with 30 cc's of effective stroke volume, which if you divide by his BSA, he lives with the stroke volume index of 15, which is not possible. So we have killed the patient. The patient is in the room, is breathing and alive, but we have killed them in paper. And that's not a good thing. So you have to go back and see what mistakes we made. So what mistake did you make? Well, look at how the alignment of this cursor is with the aorta. Okay, there's a big angle there. And look how far the sample is from the aortic valve. So we now aligned properly with the aorta, put the sample closer, and obviously got a higher TVI. And now our stroke volume made sense, all right, when we took away the regurgitant volume, and the patient was indeed alive. Now, vena contracta. Can we do vena contracta in this patient that has such an eccentric jet? Absolutely. You go to whichever view you need to get to be perpendicular to this thing. And this is the view. 3-chamber apical. Look at it. Here you're perpendicular to it. But what do you have to do? To see the richness of things, you have to look. You have to get close. So we get very close. and we identify that blue, that red, which is the flow convergence, and I have two beautiful vena contractas here, 0.6, 0.65, compatible with severe AR. Nothing else to do with this patient, huh? We do need to speak about mechanisms which are the same as MR. Mechanism number one is normal cusp mobility, but the frame or the stent, there's something wrong with it, which is basically the aorta, right? Type 2 is the same as MR, is excessive tissue, prolapse, and type 3 is too little tissue, which is retraction, same as MR. Now, you have to look at the aortic valve and imagine that this is a stentless valve that has been placed in a human biological stent. That human biological stent is the root complex. And the root complex is formed by the basal ring, LVOT, the root itself, the sinuses, and the sinotubular junction. And the most important parts that hold that valve as a stent in place are the basal ring, LVOT, and the STJ, much more than the sinuses. So look at this case. This is a type 1. It's a very interesting case because, as you can see, it's a bicuspid aortic valve. This is a TEE. This is a right-left fusion. So the anterior leaflet is opening a little shorter, and it's opening with a little bend. But look at what has happened here. This patient obviously is going to have surgery because he has a big aorta, 50 millimeters mid, large proximal, and measured in systole or diastole, the STJ is quite big. It's 41. So there is a relationship between STJ and LVOT that must be maintained. And in this case, it should be 1.2 to 1.3 STJ over LVOT. Look at what it is. So what's happening here is what happens to the MR, to the mitral valve, when it's pulled into the left ventricle, but the other way around. The aortic valve is now pulled into the aorta because the STJ is big. So instead of doing this, now, as you can see, it's doing this because it's all pulled up. See how it's doing it? That's not a normal coaptation. That's like a weird tent there. So if you dilate the basal ring and if you dilate the sinotubular junction, you're going to get AR. And this is how this patient's AR was. Okay, it was a central AR even though it was a bicuspid aortic valve because it's all from pulling. Okay? And it's raging AR, and there's a beautiful vena contracta there of 0.68, little blue, little red vena contracta. Huh? This is how a type 2 in bicuspid, typical by TEE, would look. You see the anterior leaflet, most common right-left fusion, gets underneath the other one and produces a jet. This is like full prolapse, a jet that's directed away from the lesion. Okay, that's severe AR. And how does it look if we take that patient to TTE? Well, it looks like this. It looks severe prolapse of that anterior conjoined right-left fusion and a very eccentric jet, again, directed away from the leaflet with a huge flow convergence at a scale of 87. Okay? When you see this, this is what the guidelines say. Look at the valve, look at the flow convergence. I already know this thing is likely severe, and I haven't measured anything. Good. Now, this is very nice, because for tricuspid aortic valve, the most common isolated cause is prolapse of the right coronary cusp. For some reason, we don't know exactly. We hypothesize, but we don't know. So it looks the same. Okay, it's directed posteriorly by TEE. And if you look, you can see this by TTE as well, you see the double contour. Okay, that's a double contour sign. That's my name for it. Why? Because it is not the entire leaflet that's getting underneath, it's the edge, mid to edge, that's prolapsing and generating this very eccentric. And obviously you can see the double contour sign there by 3D as well. And this retraction is retraction. Look at this thing, how retracted it is. And it's so retracted that it just makes a big hole. Now, severe chronic AR comes with universal indications for surgery, which are supposedly to be okay, you know, when you reach symptoms, in particular, or when you reach left ventricular dysfunction. They're supposed to be okay. But I'll show you the research showing that waiting for class 1 and class 2A indications is not such a good idea. And then you have severe asymptomatic chronic AR, which is where we start using EF and end-systolic diameter, and now LV volume and strain, and now CMR as well, to evaluate these patients, okay? And obviously these are being updated, but that's what we have. The European ones are out. But here's where we need to go back to basics a little bit and deconstruct the guidelines and deconstruct the ego. You see, we dress ourselves with so many masks and so many stories that we invent that we are and that we do, or that we, you know, and then we get this big bull over here, you know. This is obviously the bull by Picasso, but you can deconstruct this down to what it really is. And people, I mean, I'm scared of deconstructing myself down to that, but that's the reality of life, you know. Truth is that one needs to keep true to oneself and not lie. And most of us are just searching for comfort and inventing stories to explain our illusions and not looking at what's real, which is the most terrifying thing, which is to look inside yourself and accept yourself. That's what I think. So, always search for the truth, okay? I'm not here because I'm very intelligent, okay? I suck at math. I'm here because I have these mentors, okay? These four people. That's the reason I'm here, and that's why they're there, okay? And yes, I have passion and resilience, but it's because of them. It's not because of me. Or let's say it's between the 5 of us. So that's very important. People forget those things. People then believe that there's some form of God that came to earth to illuminate. And really your most important mandate in life is really to be who you are, responsibly, you know? This is a sonographer that had the longest hair in the Ecolab. This is like 10 years ago. So, yes, you need to use the mask, okay? And you need to use that dress, and you need to keep it tidy and all that stuff. But remember what's underneath. Huh? The truth is underneath. And precisely what kills a soul is exhaustion, secret keeping, image management. It's honesty, connection, and grace what brings you back. Half of life is lost charming other, and the other half lost in the anxieties caused by others. And everybody wants to be important. And I do believe this. A lot of the trouble in the world comes from that. Everybody wants to be important. So we have to keep in mind that even if we were lions once, we are all gonna come here. And this is what reality is. And therefore, the most important thing that we can offer is to make it our purpose to make people feel what they need to feel. What do people need to feel? People need to feel acknowledged, seen, taken into account, and heard. Okay? And we need it too, by the way. So not only our patients, it took me like 2 hours to find all these pictures in my phone, but it's really how you make people feel. Huh? And I think that that's the most important thing that you can do in your life. That's what I think. So pathophysiology, Carabello rose to fame in part because of this, because he showed that AR is a mixture of volume overload and pressure overload, as opposed to MR, which is just volume overload. So MR is a sleazy, because it plays with lowish afterload. But AR has both volume and pressure overload. So such that even if you have a very low EF patient, prognosis without surgery is very poor, you know, if the LV dysfunction is due to AR. And that has been shown before by my colleague Maurice Serrano, a long time ago, showing that the post-EF of these patients with low EF tends to increase after, and I've seen it and I'm sure you've seen you've gotten your patient with AR EF 20%. Now, asymptomatic patients. Here's the key. Echo monitoring of contractility and prognosis. Why do we use the end systolic diameter? If you look at your pressure volume loop, and remember this is the filling in diastole, then there comes isovolumic ejection, then ejection, and so on and so forth. This point of C at the final ejection is the point where you build your slope of E max, elastance, which is contractility. And therefore, the end systolic diameter is a surrogate for the poor, which are us echocardiographers, of what that contractility is doing. So it's a double marker. It's a marker of contractility, but it's also a marker of dilatation of the LV. And what's managed right now for an asymptomatic patient, and what the recommendations say with chronic AR, significant, clinically significant, is end diastolic diameter 65 and systolic diameter 50. These are absolute numbers, and EF 55. So if one of those drops or changes in an abnormal way, that's potentially a class 1 or class 2A indication for surgery in an asymptomatic patient. So follow-up is critical for asymptomatic patients, but please know this about guidelines, algorithms, and numbers. Life is not black and white, although this is a beautiful black and white Picasso, okay? It is not. Cutoffs are artificial constructs that we invent to dichotomize reality, but reality is a continuum. So it's not that if you're at 45 end systolic diameter, you're good, go. We'll see you back in 5 years. And if you're at 51, oh, you need surgery on Monday. No. 51 and 49 is the same by echo, okay? If you take into account the plus minus error. So be very careful. It's a continuum. However, these cutoffs are evidence-based and are clinically helpful to guide us. But besides looking at the cutoffs, you have to look at the progressive dilatation and the progressive EF decrease. So if you see, and that's why we see patients. So if we see patients year by year, and you're noticing that the ejection fraction started at 65, now it's 60, now it's 58, then 55, and so on, you know where this is going. If you see that the end systolic diameter is increasing and increasing and increasing, you know where this is going, okay? Very critical for sonographers and physicians. Compare the two dimensions, the 2D dimensions and volumes with the same technique done on the previous echo. Don't invent a new technique to measure this one, because you need to compare apples to apples, right? You're comparing measurements. Measurements for these patients are critical. We continue seeing glorious color and AR as a work of art. Turns out that the AR patient is a work of art. They have wide pulse pressure, systolic hypertension, they have a bunch of signs and physical examination that you can see. Like, for example, Quincke's pulses. This is synchronized, and Corrigan's pulse. You see Quincke's in systole red, and then it turns white. Even the other fingers, red, white, and every time it's red, you can see the carotid of the patient bounding in front of you. You don't even need to touch it. You just look at it. That's Corrigan's sign. These things exist, huh? And this is for real. I took this with my cell phone in an office, okay? So much that we have looked at it, and it turns out that very low diastolic blood pressures are reflective of very severe AR, and therefore are associated with death, okay? So you have to combine echo and physical examination. Now, as you can see right here, women obviously are the salt of the earth. But you have to be very careful, okay? Why? So here are the observations in the 90s of post-op survival AR. Very different between men and women, huh? Why? Because women were being referred late and were achieving those absolute dimensions much less than men. Why? Because they're smaller than men, physically, okay? It's also applicable to small men, obviously, right? So that was happening. So then the correction of that end systolic diameter index by BSA happened, and it showed that it was good. Okay? Question is, has it worked for women? So we looked at this a few, like 4 years ago or so, and we found that still women are being referred, these are people with severe AR, women are being referred a little older than men, women are being referred more symptomatic than men, but we have a winner. Post-AVS survival is the same for them now. Yet, the total cohort survival is still benefiting men. So there still persists a difference. In fact, when you look at several models, female sex is a protective factor for surgery. It protects you from surgery, being a woman. And that is not right, okay? And when you look at it, you say, well, what is wrong with women that do worse? You know, well, it's very simple. They're older, they have more symptoms, they have worse parameters than men because they are referred a little bit late. But I'll tell you something super good. 65% of asymptomatic women in this study had an end systolic diameter index of 20 to 25. And I'll tell you about 20 to 25 in 1 second. Before showing you this beautiful study by my colleagues here at Houston, AI-derived phenoclusters of aortic regurgitation, where you find two very interesting things. One, younger patients, predominantly male, those are the bicuspids, with a lot of dilatation, a lot of bicuspid valve. They have the worst prognosis. Why? Because they're young, man. Young people don't die, okay? And they also find that older patients, predominantly female, with not so much LV dilatation, are in the increasing mortality. So again, women. This is very important. And what I was referring to is that us and many others that I'm not showing because I don't have time, have shown that at 20 millimeters per meter square, death begins to rise. Such that when you reach 25, which is the current cutoff, you're well into the mortality. And this is good for women. This should be taken into consideration for women. Now, it is very important to put this in context. Most studies in AR, from here, from Houston, from Mayo, from everywhere, are mostly in the evidence-based pyramid, belong to this area, okay, of cohort studies. Okay, there might be prospective, there might be retrospective, but they're observational studies, okay? And that has limitations because you can get associations, but not causality. So I cannot tell you, go operate on your patient because my paper said so, and it's a retrospective paper where I found an association, right? But the way I look at this is that if AVR, you always run AVR with these studies. If AVR is independently associated with decrease of death, well, then the marker that you're looking at that's independently associated with death, it is possible that doing AVR before getting the bad marker may be beneficial. But the real way to prove this is to do a randomized trial, okay? So that's important to know. So I was with Bob Bono when I invited him to the ACC Latin America, and he said, Hector, how is it possible that with all the possible measurements and mistakes that one can make, as you can see, okay, we're talking about 2D diameters, and we're not talking about volumes. So we took it upon ourselves to go to that end systolic volume now, instead of that end systolic diameter. And we took, let me tell you, this was very painful to go through Bob Bono, because these patients needed to be asymptomatic, like asymptomatic. So, and again, with significant AR, and it turns out that this is the cutoff, more than 45 cc's per meter square, that we found being significant predictor of death, as you can see. Breaking survival into 2. And we also found again that it's a 20 of left ventricular and systolic diameter index that badness begins, and it's about 45, as we said, where badness begins with the end systolic volume. Now, 2 years later came the group of Joao Cavalcante, who's our neighbor up there in the cities, and they showed basically the same thing. Badness begins around 20 of end systolic diameter index. Badness begins around 45 of LV end systolic index. And they found something very important for MRI, which is the value of the regurgitant fraction of 32. That regurgitant fraction of 32 was very powerful. Now, this is, to me, a landmark study because it puts CMR at the center, and this is a study from my colleagues here, Dr. Malaji. Large study, multi-center, asymptomatic patients, all with more than moderate AR, showing obviously studying those cut points, and finding interesting things, finding that the AR fraction of 43 and again, that left ventricular end systolic volume index of 43, which is very near 45, are indeed show association. Here you go, 43, 43. And I think this is a very important study because it's obviously multi-center and has a lot of patients. So what I think about CMR is that it has very good things. Even though the studies, in my view, show a little bit of variation between the regurgitant fractions from 28 to 43%, I think it's clear that a regurgitant fraction more than 35% is equivalent to my echo more or equal to 3+. And it's significant. And you should take it into account clinically. And the other thing that echo cannot do, obviously, is tissue profiling. I cannot forget when I read and I said 9% increase in mortality per 2% increase in scar. Dr. Malafi, is that correct?
I think so.
Yes, it is. You forgot. I know. So this is very powerful. The other stuff that you can measure with MRI is indeed very powerful. And very interestingly, that LV end systolic volume, it says diameter there, volume index is the same that we found by echo. It's been shown by MRI by 2 separate groups now. Okay, so it's getting momentum. Now, where I see MRI not doing very well is in anatomic regurgitant orifice measurement because it's very difficult. That I think CT might be the key, and in evaluating mechanisms and surgical planning, and that's where I think CT might be the key. We also looked at GLS, obviously, and showed that this is again asymptomatic normal LV function with significant AR, and showed this breakpoint at -15. So what did we do? We took patients, asymptomatic patients, without class 1 or 2A indications, and we showed that when you attain those class 1 and 2 indications, here's your survival. Not very good. When you have at least 2 of these markers, and there are 3 markers, EF less than 60 instead of 55, are the volume of more than 45 cc's per meter square, and the GLS worse than -15. Which 30% of these patients had at least 2 markers. That differentiates the survival between the ones that achieve guidelines and the ones that do not develop anything, that are clean, asymptomatic, and have nothing. So obviously this led us to say patients with asymptomatic clinical significant chronic AR incur a survival penalty when they reach guidelines. If they don't, at least 2 markers of this early LV dysfunction may identify patients at higher mortality. So obviously AR management, you know how it is. It's here. There's EF and symptoms, obviously. Then there become the other ones that we spoke about. Then the importance of looking at progressive changes. And obviously, if we want to do a timely intervention, we need to pay attention to these new ones. 20 to 25, LV end systolic diameter index, LV end systolic volume index more than 45, LV GLS 15, et cetera, including diastolic blood pressure and including the information from MRI. And we kind of put it together in 2023 in this paper showing number one, never forget to correct everything for women. Number two, remember what's currently recommended for early intervention. But remember that that is changing because there are emerging parameters, as we have seen. Okay, GLS has not only been done by echo, but has also been done by CMR as well. Huh? And please note, I love the way that we did this, which is acknowledge that this is a continuum. It's not that 19 you're good and 21 you're gonna die. No, it doesn't work that way. It's that the risk of mortality increases from 20 to 25 and increases when you start lowering from 60 to 55. So these are the things that we have to keep in mind. But 2 decades younger are the bicuspid patients with more aorta dilatation, and they need a lifetime plan. And again, go back to the phenotypes, which are superb. These are patients whose mortality is 1%. Okay, they have very big. They tolerate the AR because their heart is plastic, because they are young. Okay, but you have to be very careful because if you remember the Bono papers, some of these youngsters that develop very large LVs, I'm talking 80 millimeters and that kind of stuff, they drop dead. Okay? So one has to be careful with that. Okay? And the other thing is that these patients have the lowest risks, and therefore their initial management can be with a higher risk procedure that will give them an initial 20 years of freedom. And when I talk about that, I am obviously referring, before I go there, no study that I know of has shown superiority of bioprosthesis over mechanical valves in the aortic position in age less than 60. Maybe there was one that came out in heart from Asia, and I haven't been able to read it, okay? I mean, the evidence is clear, yet patients, industry, and doctors push to put bioprosthesis in young patients. That's not right, in my view. I mean, if we're gonna follow the science, we're gonna follow the science. If we're gonna follow the money, we're gonna follow the money. So we need to decide, right? So, the Ross procedure. This is a beautiful study by El Hamamsi, who's my dear friend, showing that survival with Ross is equivalent to the population, and survival with mechanical or bioprosthetic is, in other words, mortality is higher. Okay, now, this is not a randomized trial, okay? This is a New York registry. It's very, very well done methodologically, meaning that it's propensity matched, et cetera, Now, life gives you things and you get very lucky. And I got very lucky to end up in the middle of these guys. Okay, these guys are also the salt of the earth. You know, Jebrin El-Khoury and Johann Schaefers and Magdi Yacoub and all these people that are the fathers of aortic valve repair, and are the fathers not only of aortic valve repair but the fathers of preservation of aortic valves. This is a critical thing for these young patients, huh? So we came up with a new bicuspid classification, which is a huge document and this and that, and we included also important surgical information. Obviously, it's easier to repair a valve that has this angle because you're only dealing with one surface of coaptation, and here you start dealing with 1.5 and now 2, and so on and so forth. And sometimes these ones have to be treated as trileaflet and not bicuspid, you know? So, bottom line is that they developed very, very interesting, fascinating stuff. They developed, particularly Johann, a caliper. And they looked at this in an academic way, for real, you know? And they said, well, we need to get this root and this valve back to its normal configuration. So we need to be able to study prolapse in the OR. So they invented the effective height, which is the height from the basal annulus to the tip here. If this height is low, the valve is prolapsing, obviously, and you can measure this height intraoperatively, okay? And obviously, there's a significant number of parameters, mostly 5, Okay, as I told you before, annulus, STJ, coaptation length. Geometric height is just the length of the leaflet. And the effective height, which is the measurement of prolapse. Now, you can do that with echo for planification of surgery. I think CT is going to be the big mother that's going to do this thing. So look at this patient of mine, 24-year-old male, bicuspid, severe AR, severe LV dilatation, and Crohn's disease. Okay, now look at him. He's a right-left fusion without a raphe, clean valve, no calcification, angle of 180 degrees, beautiful for repair, beautiful for primary repair. Very prolapsing right-left fusion cusp there, getting under the other one. Okay? And as you can see, obviously, the regurgitation is massive. Don't get confused because this is eccentric. This thing is massive leakage, huh? So, again, prolapse. So, and very big LVOT, which is typical of these patients, with a normal STJ, normal ascending, normal arch. What did he want? He wanted, 24, huh? He wanted somebody to do a primary repair of his bicuspid valve, and if not possible, to do a Ross. And at that moment, in my hospital, the surgeon that does repairs could do the repair, but could not offer a Ross plan B. So I sent him to Ismail, because my job is my patient, not the Mayo Clinic. So I sent him to Ismail, and Ismail took care of him. Look at that. They opened the valve. They put stay sutures to maintain it in good. They measure the length of the leaflets. That's the geometric height. Then they measure the effective height to determine the amount of prolapse. Okay? And this is the part that surgeons don't want to do, obviously, which is dissecting that root all the way to the VA junction, to the ventricular arterial junction, because it's very dangerous. Obviously, the coronaries are there, and you can cause VSDs. You can do a lot of damage, okay? But these people do it, you know? So he's creating, basically, an annuloplasty ring. You need to stabilize the annulus in these patients with bicuspid valve and AR, because their annulus, generally speaking, are huge. If you don't stabilize it, they're going to leak again, because we spoke about the root complex and the importance of the annulus and the STJ. Okay, now he's plicating. This is the way to resolve prolapse. Plicate. The leaflet is like this, prolapsing, and you plicate it and bring it up. Okay, that's the way it goes. And now he's putting a dacron as an annuloplasty. And he's doing his suturing of that with a Hector in between. And now he's doing his final measurements. Look at the coaptation of that valve. Look at that beauty. He's doing his final measurements there, making sure there's no residual prolapse, no residual anything. And then the patient comes back to me. And I see him, this is like 4 years ago. And this is how his echo looked. It's like if he had never had anything. So we need to be very careful with that and pay a lot of attention. And remember that all of us here, non-invasive people, including sonographers, including techs, are warriors. A patient wrote me a note telling me that I was her big hero, and she thanked me for service and dedication in the management of her successful life-saving surgery. And I responded back to her, and I told her the truth. The hero is the surgeon who did your surgery, ma'am. It's not me. And she was she changed my way of things because she responded back, and she acknowledged my confession of not being a hero, and she accepted that I was a non-hero. Yet she said that if I was not her hero, I was her warrior, because I had fought for her, to diagnose her, to take her what she needed to go, and to do everything for her so she could get what she needed. And that's what we are. We are warriors. That is our job. I always bring my clapping mitral valve in case people don't like the lecture. So I have a mitral valve clapping for me. So that's it, folks.
what a tour de force. Questions for Dr. Michelena? Dr. Zogby.
Hector, this was amazing. Thank you very much
For not only the science, but your personal perspectives and your patient's perspectives. I have one question that relates actually to Dr. Malhabshi and Deepan Shah's work regarding using AI to look into our population, which is very different, right? I mean, the younger individual versus the older individual. So the question is, should we wait a little longer in the younger individual?
That is a super question. That is a super question. And here's the deal with that question. If you talk to surgeons that repair aortic valves, those valves get damaged by the AR. So if you have a really big ventricle, okay, and you have a really big ventricle, and you remember Bono's patients in 1991 dropping dead, not because they had coronary disease, but because their ventricles were huge and they were completely asymptomatic, okay? And you say, can I offer this patient a good thing because he's a very low risk patient, like a repair that will rid him of this crap for 20 years until we talk later, or a Ross that will rid him of this crap 20 years and then we'll talk more, I think that obviously it's a case by case, but I think that one has to think about that because there's that happening on the other side. There's something else happening on the other side, which is people that you let the ventricles get too big, they don't recover their ventricles very well.
The follow-up question is, in those patients, is it harder to repair later? And
Yes.
What I've seen also, they start developing calcifications because of stress and other things, so will become even more difficult from an anatomic point of view.
So again, as we said, that chronic turbulent and abnormal flow to that valve damages that valve. So exactly what you said, and causes changes, fibrotic changes in that valve, and then it's not going to be repairable.
Thank you for coming, and your presentation was outstanding. Really wonderful. So, as a surgeon, I think that most of the aortic valve regurgitation should be repaired, if not all of them, unless there is an endocarditis process and the leaflets are gone. Because
I agree.
Because this is what happened 50 years ago now with the mitral valve. So there's no reason. I mean, what makes difficult to repair the aortic valve is that it's very difficult to test the aortic valve. And personally, I have more than 20% risk of second cross clamp, because I usually, when I do the repair, I accept only a perfect repair. Otherwise, it's better to replace the valve.
You have to.
Yes. And agree with you. As a surgeon, I like to repair early because a chronic regurgitant jet can damage further the leaflets.
Yep. By the way, there's a state-of-the-art article that I ended up in the middle with all of these surgeons that I adore. And I did the echo part of, and some of the epidemiologic part, which is in the European Heart Journal, and it's state-of-the-art aortic valve repair, both for bicuspid and tricuspid. It's European Heart Journal 2025. And there are European Association of Cardiothoracic Surgery guidelines coming out for repair.
Hey, first off, thank you so much. That's really outstanding presentation, very entertaining as well. So I want to push you a little bit further on this. We've seen that the guidelines have kind of evolved as far as when you would think about intervening on a patient. But let me ask you, do you think 10 years from now, we're going to have one number for all patients? Or should we start to go multidimensional and say, really, you need to look at, depending upon your patient phenotype, a different threshold for when you intervene? And obviously, it depends on what the potential intervention options are, whether it's repairability versus likelihood of getting a replacement versus surgical versus transcatheter. In other words, do you think we're going to move to an era where there's not a single number in the guidelines, but rather it's a table that takes into account multiple dimensions?
I mean, I think we're already kind of seeing it a little bit, you know. My deep thought about that is that biology is, although there's magnificent deep organization, biology is chaos, and chaos cannot be organized with one parameter. Human life is chaos because there's many factors going in, so you cannot organize it with one parameter. That's why we appeal to AI to separate these phenotypes for us, you know, and help us, you know. And I absolutely agree with you. There's not going to be one measurement or one, you know, particular modality that's it. You know, we got it finally. I don't believe so. I think it's going to be still a case by case, and I think that probably AI is going to help us a lot in classifying these cases by risk and thinking, what should I do with this patient? You know, and then obviously comes the other part, which is, how am I going to treat this patient? You know, I mean, what am I going to offer this patient? Do I know a surgeon that knows how to repair valves? You know, so I could not be more agreeable.
And let me ask you one other follow-up question. What we talk about right now is mechanical treatment. What about medical treatment? Is there, what are your thoughts on evolving therapies that could help slow down the progression of the biology?
Listen, that's an interesting thing. And there was a New England Journal of Papers, Sconamiglio, right? 1,000,000 years ago, 100 years ago, with the calcium channel blockers. And then Evangelista, one of my mentors, published a paper using those and show that it did nothing. Currently, my position is, you have a mechanical problem that you cannot cure with a medication, which may happen for AS. But for AR, you have a mechanical problem that you cannot cure with a medication. It needs a mechanical solution. So in my mind, I don't want to give little things to hamper with the evolution of this disease and see if there's a patient that's really going to get sick with this thing and it's going to advance quickly. I mean, I've seen young patients on treadmills developing VT, and I've seen all kinds of horrible stuff in young patients, you know? So that's kind of what I think. Last question.
Very comprehensive overview. A question for the older patients who present with moderate AS, moderate AR. What are special considerations that you'd look at, especially when you can offer them something like TAVR, not as traumatic as surgery? How do you assess these patients when they're symptomatic?
Well, listen, I'm going to answer you with this. I'm working with a brilliant Chinese PhD candidate and we did a study looking at remeasuring calcium score by CT in more than 4,000 patients. And we addressed particularly that area of moderate, okay? And especially the area that's not mentioned anywhere, but everybody talks about, which is moderate to severe, you know? Has moderate to severe AS. Is that in the guidelines? No, it doesn't exist, okay? But I talk about it all the time. So there are ways by calcium scoring to determine who of those patients whose valve areas are more than 1, for example, but less than 1.5, okay, which would generally